so much for joining me this lovely Friday in Southern California. My name is Julie Hirschberg. I am the owner of Reactive Therapy and Wellness here in the Los Angeles area, and I'm excited to join you every Friday to share a little bit of what we are learning and what we're doing. And this Friday is no exception because last night we have one of our great mini courses that we host throughout the year for our Movement Disorders Fellowship, which, by the way, our Movement Disorder Fellowship is open right now. If you are a physical therapist who wants to specialize in movement disorders, we are in our 6th year and would love to have you as a part of our fellowship. So the application is open and you can find it on our website. But anyway, as part of our fellowship, we do mini courses that go a little deeper into things that will affect people with a movement disorder, including Parkinson's disease. And last night we talked about freezing of gait, a very common problem in Parkinson's, and something with a lot of research in it to show a lot of different ways that we can help people with freezing. The last time we did this course was over 2 years ago, and it was just astounding to me about how much has come out in the literature since that time. And for the first time this year, we put together a little pocket guide to go with this. And isn't it funny? It actually was in my pocket. You can see that I folded it up and put it in my pocket. So it's literally a pocket guide, everything in one page, front and back, of how to assess and treat freezing of gait. So this is something that I made while I was working with Natalie Thomas and Brittany Charlet, our amazing therapists who put together this course for us last night. And by the way, this course was just overflowing with a lot of great examples and ideas. I'm just going to give you a piece of it today. We're going to talk about what are the contributing factors to freezing of gait. This is where the literature has been really nice in the last couple of years, is to open my eyes up to a couple of other ideas. I will go through our pie chart. By the way, this is free. You can download it from us. We make a lot of these little pocket guides and cheat sheets all year long, again, just to share what we're doing and make your life easier. So I'll share this, share how to use it. It includes some of the best ways to measure freezing of gait so that you can show change and improvement, and then some creative ideas for intervention. Because I don't know about you, but sometimes I just get a little stuck. So let's dive in. Let's talk about the contributing factors. This is where we get to our pie chart. If you follow us a lot, you know we love pie charts, but this one is specific to freezing of gait. And the reason I really love a pie chart versus like a list of things is that you can change the size of each piece of the pie. And this is one of the really important things with freezing of gait, is that for each person, the size of the contributing factor might be different. So let's talk about these contributing factors. Let's start at the top of the pie, which is actually cognition. This is a really big contributing factor. I think it can go under tested, and I think this is really important for us to look at in treatment. So when we look at cognition, from an assessment standpoint, we may want to partner with a neuropsychologist to do some pretty in-depth testing. This is something we have a neuropsychologist on our team. I'm so thankful for that. And she's going to join us in our Brain Bites community sessions this week to talk about how she tests this, how that will inform our practice. So I highly recommend that. As therapists, as PTs and OTs, we certainly do a lot of screening, like using the MOCA or the mini mental. I love the trail making test, trail making A and B particular, because in the trail making B, there's that nice set shifting. So you can use the trail making I love the tug, the timed up and go, and then the tug cognitive and the tug motor to add on that secondary task with those. It's another great way to assess. And the freezing of gait assessment, because it adds on those other dual task components, it's a really great way to add in the cognition as a part of your freezing of gait assessment. So that's the cognitive piece. That's really important to measure and then take into treatment. So at the end, I'm going to go through each of these categories and just give a few creative ideas that we talked about last night for treatment. So cognition is at the top of our pie chart. We go into psychosocial. There's been a lot of great research recently looking at how anxiety can contribute to freezing of gait, possibly because this also takes up some of the cognitive reserve, right? So this is a very important piece that we have to consider and incorporate into our assessment and treatment. We like to screen it. I like the hospital anxiety depression scale, particularly as a screen. But again, having a neuropsychologist on board to screen and intervene in this realm is a game changer. This is huge. So that's the second piece of our pie, psychosocial. Then we go to autonomic. This has been coming out a little bit more in literature. Just last year, there was a nice little study on vagus nerve stimulation as an autonomic contributor, and people improving with vagus nerve stimulation for their freezing of gait. How cool is that? And how cool that we can address some of this without a stimulator, right? So we can tone our own vagus nerves through autonomic training. So testing autonomically through seeing somebody's response with breath and their movement, but also testing heart rate variability is a really great way to look at somebody's autonomic control. So we talked cognition, psychosocial, autonomic, biomechanics. I know this is bread and butter for physical therapists, but when it comes to freezing of gait, you can't lose sight that somebody's propensity to be forward may be contributing to their freezing of gait in that forward direction. So a forward head, thoracic kyphosis, limited hip extensor range of motion, or hip flexor, excuse me, range of motion, all of those things can contribute biomechanically to the freezing of gait, and you need to test them. So biomechanics, motor control, huge one, right? So what is that person's coordination like, their initiation, their ability to shift weight? How do they respond to external cues? All of those would be considered part of that motor control assessment. And I would say some of that, the testing of the timed up and go and the freezing of gait assessment also fit in that piece of the pie. Moving around our pie chart to sensory. So we need to test the sensory system, particularly sensory organization, visual perceptual, kinesthesia. All of those can be impaired and directly contribute to the freezing of gait. And then finally, maybe last but very not least, is just plain dopamine. We need to ask people about medications because some of the freezing can occur because the medications aren't optimized. And also, man, this is one of the things I see over and over again, is when somebody can enhance their own dopamine levels and their BDNF through intense exercise, we see a difference in their freezing. We see a change. They improve without even direct intervention on the freezing. So just that intense exercise, that is huge. So I would argue from that pie chart, from cognition, psychosocial, autonomic, biomechanics, motor control, sensory, that dopamine level, we need to assess all of it. And maybe not all of the factors are the number one thing for a person. Usually you can find the one where there's most problem, and that's where you're going to direct intervention. I heard from people last night in our course, like, well, there's so many things I can do. What should I do? Well, first, assess what part of those contributing factors is most salient. Like, what is the biggest piece? For a lot of people, it's cognition. For other people, it's simply their biomechanics that kind of like tip them over the line. For other people, it's purely just getting them that intense exercise. But I would say for the majority of people, there's some sort of combination of approach that is the sweet spot. So then you want to take that pie chart and individualize it, assess the person where they're at, set up a plan to address those underlying factors, and then have some really great creative ideas to get there, right? So, by the way, in this pocket guide, we have for each of those categories from the pie chart, we have both the assessment and the treatment. So assessment, how to assess each of these areas, and then treatment ideas. One of the things that we saw, so I'll just give you a few of them, like biomechanically, one of the things that we saw last night in one of the people that Brittany is working with is working on some thoracic mobilization. So she did a really nice mobilization where the person was sitting with a ball in front of them, and she did some thoracic mobilization and mobilization with movement. She did a before and after walking, and he was so much faster, longer stride length, more upright just after, like a minute of mobilization. So a big improvement just with that. So that would be a little thing that you could try, and it wouldn't take a lot of time, and it's got a lot of benefits for many other things as well, simply addressing the biomechanics. We talked a lot about the optimal theory last night. So in addressing some of the motor control, the sensory, and the psychosocial, because the optimal theory promotes autonomy, enhanced expectancies, and having an external focus. The external focus, as we know in freezing, can be really important. And we talked about a ton of different external focuses. So we talked about music, and rhythmic auditory stimulation. There's been some really nice studies with that. So I love using music myself in any kind of treatment. So having music to help initiate weight shifts and that rhythmic movement to decrease the freezing, that incorporates an external focus for sure and can then optimize motor learning for a person. We also talked a lot about some telehealth pieces where you can incorporate this at home. And telehealth has the benefit of learning in the context where they live. Because I don't know about you, but a common thing that happens with freezing is people come into the clinic, it looks great, they're doing great, and then at home they're like, no, I'm still freezing going through that doorway. Well, in telehealth, we can actually work on the freezing through that doorway. And Ari, our current fellow, actually shared a case within the course last night and talked about how she's used all kinds of targets in the doorways. She's used a person's care partner to help with that carryover via telehealth. So I thought that was great because sometimes it can be a little intimidating to try some of these things via telehealth, but using the external targets and external focus in telehealth was a really great way to get that carryover of results. So we talked biomechanics, motor control, and then we did talk a lot about cognition and how you could incorporate this. Brittany Charlet showed a lot of great examples of using the Stroop and using inhibition to drive some of that cognitive load for a person. But I want to say some of the conversation we had in the course too was like, well, what if the person can't do that? So there was a lot of discussion about how we can grade the task and grade the exposure to the difficulty of the task, which is really, really important. So even just the straight up Stroop task where you see the word and it's written in a different color and you have to kind of inhibit your desire to say the word and not the color that it's written in. It's a really tough task. And so that alone might be all that you do by itself without a motor task, or you add on an easier motor task like being on the bike, or like a sit to stand and not walking, for example. So we talked about how important it is to grade that. So you might see a lot of like great activities or ideas, and we might share ideas, and just not work for the person you're with because of their level of cognitive impairment, for example. So really severe cognitive impairment, you might have to like take a few steps back and do some errorless learning. If they don't, if they have a really mild cognitive, you can do some go, no go boxing. That's one of my favorites. I love the Clock Yourself app. Everybody should have the Clock Yourself app. I love doing a moving trail making. So trail making is the 1 to A, 2 to B, and you can set that up on the floor for the person to go through. It's a really nice way to challenge set shifting. So again, lots of great ideas, but you really have to tailor this to the level of the person that you're working with. Final piece of some creative ideas that we talked about last night was with the autonomic nervous system. So I mentioned there's that study looking at vagus nerve stimulation, improving freezing in people with Parkinson's. And how can we stimulate the vagus nerve naturally, but through our breath? So we discussed movement with breath. And I find breath really, really powerful. So some of the things that I've done are simply, as we're walking, inhale for 2 steps and exhale for 4 steps. So that's an example of using that extended exhale, of toning the parasympathetic nervous system as somebody is moving. And particularly, you could then do that through a doorway or do that across a threshold, do it into the elevator, those particular situations or contexts where a person is having freezing, but incorporating the breath and the autonomic nervous system. And then what I would really argue is that you should be toning that autonomic nervous system outside of the movement too, so you have that really available to you. So practicing those breath practices, the grounding practices, all of those outside of just in the movement. But I like to see them in the movement because then it shows like, oh, wow, when this is available to me, my movement improves. So, so we spent a lot of time talking about the autonomic nervous system, one of my favorites last night. So there you had it. We talked about the components contributing to freezing and assessment pieces that can go with those components, and then some ideas that we talked about from our course last night, all that correlate with our freezing of gait pie chart and this assessment treatment pocket guide that we have available for you. So I'll put a link in the comments. You can download it. It's free. Use it. Honestly, we put together these things to make the neurotherapist life a little bit easier. And we take a lot of what we learn and just put it into an easy to use package. So here you have it. So I'll put a link in there. I'll put a link to our course too. So if you wanted to dive deeper, you can take all of our fellowship courses and train like a fellow with the learning. If you really love movement disorders, it's a great way to go. And I will be here next week to share more with you of what we're doing and what we're learning. Oh, one last thing, by the way. Speaking of movement disorders, we are hosting a free webinar in a couple of weeks on neuroplasticity and dystonia. It's a Q&A session with an amazing group of physical therapists and researchers on our presentation that we did at CSM. So if you're interested in learning more about that, I'll post the link too. It's a free webinar that we are doing with these other therapists. We put the course on together. So thanks so much for joining me today, and I will see you next week.